Hello.
Hello.
Hi.
Hi. I don't want to share my screen, so could I just, I could see you. Do you see me?
Is that you, Gabby?
This is me.
Oh, yes, I see you.
Good. Can you see me okay?
Yes, it's fine. We'll
Yeah, the
just,
lighting is kind of weird in here. I'm in my office right now.
no, me too.
Okay, so let me move the light a little bit.
Okay. And what I'll do is I'll allow everyone to hang out while they join. Let's go ahead and get started. And for those that come a little bit late, we'll allow them to just catch up on the video. But again, just so it's a pleasant experience for everyone and our speakers, keep your lines muted. If not, then I will use my superpowers to mute you anyway. So it's better you do than I do. Send your questions in chat. If it seems like we're not asking them, it may be because I know it's coming up in a slide or two, but we will get to the questions. Again, the doctors and therapists will be glad to answer questions on first episode treatment and psychosis topics, but they are not your doctors. They're not treating particular patients, so no specific patient information, just general questions. We'll begin promptly. I'm already lying to you, right? We're late already, but educational session is being recorded and the webinar will be available on our site under webinars, and then the slides under recording, under downloads. And if you want a certificate of attendance, send an email to contact@acmionline.com and we will get that out to you. And with that, I'd like to turn it over to Larry Villano, who is the CEO of Resilient Healthcare, because he will do a much better job at introducing our guests. He knows them better. So rather than me just reiterate their credentials, he can tell you a little bit more about them so you get a flavor really of who they are and what they do. So with that, I'll hand it over to Larry.
Thank you, Lori, very much for that. And I want to say thank you to ACME for sponsoring this event and allowing us to present today. It's a wonderful opportunity. I also want to recognize our colleagues over at Valleywise who do first episode psychosis services as well. I just want everybody to know that we just think the world of our colleagues over there. I think maybe some of them might be on the call today. So I want to send a shout out to Dr. Cowdery. She and Dr. Brazy have been working quite closely on aligning our respective programs, and just think the world of our colleagues at Valleywise. With that, today we have Gabby Becerra, who's one of our wonderful clinicians in our first episode psychosis, or FEP program. Gabby brings many years of experience in grief, trauma, psychosis. Over the last few years, she's been delving deeper into some of the nonverbal trauma responsive therapies, looking to use those to complement our first episode program. So it's a great honor to have Gabby with us today. We also have Dr. Randy Brazy, who's our Chief Medical Officer. One of the thousands of reasons he's at Resilient Health is because, as a psychiatrist, he understands and really appreciates the value of trauma and psychosis, and he brings a lot to the table as far as looking at nonverbal types of therapies to complement our verbal and our psychiatric medication interventions to help with schizophrenia and other disorders. And we might even get into some of the polyvagal stuff that Dr. Brazy brings to Resilient Health. It's kind of a lens of how we look at the individuals that we serve through the perspective of our nervous system, which really helps to reduce trauma and stigma. So with that, I know we have a lot to talk about tonight. Without any further ado, I'd like to turn it over to Gabby. Gabby, take it away.
Thank you so much, Larry. I really appreciate all of you being here and being part of changing the course of schizophrenia. So let's get into it since we have a lot to cover today. So this is what we have for today. We have, first of all, a psychosis overview, so we have a better understanding. We'll be discussing, of course, the first episode, psychosis intervention, all the psychosocial treatments that we have, as well as pharmacological treatments, which Dr. Bracy will talk about. And we'll also talk about some stories and testimonials that we have from people who have been through the program. So let's start with the psychosis overview. And so first of all, let's talk about, well, let me tell you, we'll talk about psychosis in general, since we don't only work with schizophrenia, we work with schizophrenia spectrum disorders, and we'll get into those in a little bit as well. But let's talk about what psychosis is not first. There's a lot of myths about it. So first of all, it's the idea that people who have psychosis, they have split personality. And that is not what happens. Split personality is called now dissociative identity disorder, resulting from severe trauma. And schizophrenia is a thought disorder in which people lose contact with reality. We'll talk about the symptoms in more detail in a little bit. The other misconception is that people with psychosis tend to be violent, and that is not true either. Actually, it's more common for individuals with psychosis to be victims rather than perpetrators of violence, or to self-harm even. People with psychosis can't hold a job. That's not true. Even if people have symptoms, they can, they can work, they can lead normal lives. And actually, people with psychosis tend to do a lot better if they work. Bad parenting is a cause of psychosis, schizophrenia. There's absolutely no evidence to show that psychosis is caused by bad parenting. Psychosis may have a genetic component, but even if a parent has psychosis, the chances of the offspring having schizophrenia is less than 25%. There's another idea as well that people with psychosis tend to change quickly. So they might be one way right now, and then tomorrow they're acting differently. That's actually not true. So what happens is that symptoms tend to surface over time. So it's a slow progression. People may be kind of isolated initially, maybe have what's called flat affect, where they're not really displaying a lot of emotion. They may have decreased participation in activities. And then after a while of having those symptoms, then that's when they have a psychotic break. They usually have some, sort of warning signs before an episode, change in sleep, eating habits. So it's more of a slow progression. And then there's also this idea that people who have psychosis have to be hospitalized long-term. And that's not true either, especially because the recent research that we have and the treatment that's recommended, it's a combination of outpatient care. So we're talking about groups, we're talking about individual therapy, we're talking about medication, and sometimes acute hospitalizations. So that means that they'll be in the hospital maybe for a week or two to have a medication change, be stable, and then they return to outpatient services. In the 3 years that I've been working in the FEP program, I haven't seen anyone, not one person who has been hospitalized long-term. So now let's talk about what psychosis is. Psychosis is a cluster of symptoms. It's not an illness itself. The way I kind of think about it is if somebody has a fever, so it comes with some, certain symptoms that you go through, hot and cold, you're feeling kind of ill all over, your body may ache. But you are not diagnosed with a fever if you go to the doctor. You are diagnosed with a bacterial infection or heat exhaustion or some other virus. So psychosis is sort of the same. It's a cluster of symptoms, a group of different experiences that people go through. But then there's an illness, a different illness. So schizophrenia is the illness that you're diagnosed with, but in psychosis is a part of it. Psychosis is a lot more common than we think. Approximately 100,000 young people experience psychosis each year. This is as many as 3 in 100 people, or 1 in 33 people roughly, will have an episode at some point in their lives. Typically, this occurs during adolescence or their early 20s. And psychosis, as I mentioned earlier, is a disruption to a person's thoughts and their perceptions, of course, and it makes it difficult for them to recognize what's real and what's not. We can think of psychosis in 3 phases. We have the prodromal phase, which is the first signs that we notice. This may last up to 5 years. In the prodromal phase, people may start noticing some changes, some signs, but not fully, hallucinations, delusions, which we'll talk about in a second. So some people may have like a vague, feeling of suspiciousness, maybe some depression, anxiety. They may experience some tension, irritability, anger, mood swings. Usually parents tend to bring their kids in because of increased anxiety. And then it turns out that they were having a prodromal phase of psychosis. So some of the symptoms as well may mimic ADHD, and people who have those symptoms, they may be on stimulants, which is not what people who have those symptoms need when it's a prodromal phase in psychosis. Other things that may happen is there's a change in memory, concentration, they may be slowed down a little bit. They may have some odd ideas or vague speech issues and things like that. And then after having some of those symptoms, people may notice, things here and there, but they don't know 100% what's going on yet. After people experience that, then they go into the acute phase, which may last 1 to 2 years. And then we'll talk about the symptoms in just a little bit. The goal in the acute phase is to decrease the time that psychosis goes untreated. And then after that, we go into what's called the post-psychotic phase. And our goal there is to maintain stability. This is the treatment or recovery phase. So now let's look at the actual symptoms of psychosis. This is what happens during the acute phase in the 1 to 2 years. So first of all, we look at positive symptoms. And when we say positive symptoms, we're not talking about something nice or pretty. We're talking about something that's been added to the person's experience, something they didn't have, but now they do. So the first thing is hallucinations. I'm sure you've heard of those before. The hallucinations are the voices. They affect the 5 senses. So people might see things, might hear things, they may taste or smell or feel things that are not there. So the biggest one, the most common usually is the auditory hallucinations or the voices, followed then by visual hallucinations. People can have multiple hallucinations. They can have one, they can have more auditory than visual, only auditory. And if we go back to the most common ones, the auditory hallucinations, every single person has a personal and unique relationship with their hallucinations, especially the auditory. Some voices may be very, very mean, others may be benign. Some people experience what's called command hallucinations, and that's when the voices are telling them what to do. People may have whispers. People may be happy with their voices as well. I worked with a person at one point who had 5 voices, and they were, I believe, 4 were female, 1 was male. And when talking about getting rid of them, she didn't want to because they were her friends. So everybody develops different relationships with their hallucinations. People may have internal ones where they hear them only in their head, and people may have external ones where they hear them as if it was someone else talking from outside. So let's see. Delusions is the next one. So delusions are false beliefs that people hold very strongly, despite evidence that their beliefs are not true. So a person who's experiencing a delusion might believe that he or she's being followed or watched by the government, or people tend to have a lot of religious delusions as well. There are many types. So we have the paranoid, which is feeling, or persecutory, feeling like there's someone watching or following you, out to get you. Reference, which is the idea that you're receiving messages that only you can decode. This may be from the newspapers, billboards, the TV. Some people may experience somatic delusions, which means that it feels like there's something wrong with their body, a specific organ. Grandiose delusions, this is where the religious hallucinations may come in at times. People feeling like they are bigger, better, richer than they really are. Control, delusions of control as well, feeling like they're being controlled by some external force other than themselves. And thought insertion, like their thoughts are not their own. People may also experience in the positive symptoms, the disorganized behavior, thoughts. When you have the disorganized thoughts, it usually shows up in speech, the way people are speaking. Their words might not make sense. They might be jumbled together. They may respond too fast or too slow. They may be confused in the way they respond to things. You might ask a question and the response has nothing to do with the question you asked. People may have trouble concentrating or remembering anything. And as far as the disorganized behavior, it's anything that may be unacceptable or inappropriate in the social situation. Maybe childlike behaviors, aggressive or exaggerated behaviors. And sometimes people may also be a little clumsy when this is happening.
Gabby,
Now,
or
go ahead.
Dr. Brasi, we have a question that was asked. If someone has a visual hallucination over a auditory hallucination, does that indicate severity of the disease?
That's a good question. I think it's different for every single person. And we'll get into that a little bit and how the disease is experienced for each person. There are so many factors involved and so many genes involved as well. So it doesn't necessarily mean severity. It's just how the person experiences. Everybody's presentation is very different. I don't know if Dr. Breezy has anything else to say about that.
Yeah, I mean, and I think you were definitely right on, Gabby, is that auditory hallucinations, or the voices that people, or noises, are the most frequent or the most common. Traditionally, they would often say that if someone has predominantly visual stuff, you know, maybe they're actually going through a withdrawal of something, or maybe there's some sort of medical issue. So for example, also people who go through like detox from alcohol often will have that sense of something crawling on the skin. So sort of as you go from voices to visual to tactile, then to olfactory, you're much, much more likely to have something medical rather than a psychiatric condition. But you're right, Gabby, it doesn't really tell you anything to do with severity of symptoms, although it's a very good question.
Yeah, thank you so much. So let's see, okay, negative symptoms. So let's talk about those. Negative symptoms, again, because you're subtracting something from the person's experience. Before they had a motivation, they were more active, and now those things are not happening. So here you're having reduced motivation, as I said, reduced display of emotion. So this is what we call flat affect. We may have reduced speech. People may not know what to say. They have a harder time thinking of what to say. Reduced enjoyment from pleasurable events as well. So those are things that happen. It's very similar to depression. Sometimes it's kind of hard to distinguish initially, and this is what you may see in the prodromal phase. So also, once medication is introduced, let's say that you're having the acute psychosis phase, and people are having positive symptoms, solutions, hallucinations, and then you're introducing the antipsychotics, some of the negative symptoms may return as you're treating the positive ones. And this is something that we, of course, deal with in treatment. Something else that happens that sometimes is not mentioned is the cognitive difficulties that people are experiencing during psychosis. So there may be a decline in some of these areas: memory, attention, problem solving, recognition of other people's emotions, and processing speed. This doesn't happen to every single person who goes through it, but it can occur. So it's something that we also look at during our treatment.
Now, Gabby and Dr.
Sure.
Brazzi, we have another question. With auditory hallucination, does the brain physically reverberate, causing actual sound? Is there any science behind that?
I'm going to let Dr.
I
Brazzi answer
apologize,
that.
I have dogs barking right now, so please forgive that. It's the,
They're trying to answer, right?
yes, they are. So if you can hear me over the furious barking, the quick answer is it's a very interesting question, but it's not as far as we know. So what happens is that the circuitry that registers sound, so that goes from the inner ear to the brain, those circuits actually get activated. And so they get activated as if a real sound is coming in, but it comes from a different angle. So the quick answer is no, there is no actual sound that occurs within the skull or the brain, but the circuits involved in hearing do get activated. Very similar as if with a visual hallucination, if you're seeing something that's not there, those same circuits that are behind the eyes and the optic nerves are the ones that seem to get activated and create the impression that there is something that's being heard or seen in the absence of really any stimulus. And so we differentiate these, by the way, from an illusion. An illusion is where there is something there or some particular sound, but you're not actually hearing or seeing what you think it is, you're just misperceiving it. That is not seen as a psychotic symptom, incidentally. It has stopped, just as I have.
Okay. Next slide.
Yes, thank you. Let me see. Yes, so now let's look at some of the signs and symptoms that people may experience. And these are some things that, again, you may see during the prodromal phase. People may have thoughts of suicide or even attempts. And from, talking to a number of people who have experienced these things, people don't typically want to die. It's just they're really going through very difficult changes during an already difficult time in their lives. And this is when an individual is making sense of who they are. We're talking about adolescents and early 20s. So people are making important decisions about themselves, their futures, going to school, working, things that are hard as they are. It's a difficult stage in life already. And now they're having to deal with symptoms. So people don't typically want to die. They just are having a really hard time. They want the pain to stop. So what I typically do here is, or what we typically do here is, we try to normalize that this is happening. This is common for people who are, think about times you have had a hard time in your life and you just don't want to be here. So of course, people going through these symptoms are feeling the same way. So we just normalize it and try to help the person move forward from there and then find ways to cope. Other things as well is withdrawing from friends and family. So people's self-esteem is affected at times. They have difficulty connecting with other people, navigating the world with their symptoms now. Of course, the hallucinations more in the acute phase. Sometimes it's really hard for people to themselves after having hallucinations, especially when there's insight. Having insight means that you are aware that something is happening. When people don't have insight, is the hallucinations and some of the symptoms have completely taken over. So it makes it hard to trust themselves and of course other people. There's a decline in self-care as well that people may experience. There's a lack of motivation, the apathy, being consumed by some of the symptoms as well. Emotions may be too strong or maybe not at all. So that's something that also happens. There's increased anxiety or depression. Some people may experience an elevated mood where they're happy, active, high energy, they have little sleep. So again, this is what kind of looks like ADHD. And sometimes just people have an overall numbness as part of it. And it's so different for every single person. Something else that happens, of course, is the persistent, unusual thoughts or beliefs, which are the delusions, and trouble concentrating or thinking clearly. Again, everybody presents differently, but one of the things that I have noticed that affects everybody as a whole in different ways, different degrees, but it's trouble concentrating, trouble focusing on things. So let's move on to the next slide. And this is about the different diagnoses that we have. As I said, when we're talking about psychosis in general, not just schizophrenia, because we do work with other disorders as well. So the first one that we have is the brief psychotic disorder. This is a sudden short-term display of psychotic behavior, the hallucinations, delusions, and this occurs typically after a stressful event, followed typically again by a full recovery. This is rare in developed countries, more common in developing ones. And if the symptoms persist, the diagnosis must be changed. This typically lasts less than a month. The next one is the schizophreniform disorder. This is what a person in the prodromal stage might be diagnosed with. This lasts at least a month, but less than 6. And in many cases, it does become a diagnosis of schizophrenia. Schizophrenia is the next one, of course. It just contains all the symptoms of psychosis. That's the illness that's diagnosed when a person comes in with some of the psychotic symptoms, and it lasts at least 6 months or over 6 months. Schizoaffective is the next one. And this has the psychosis component and a mood disorder as well. So people may come in with psychosis and depression, and they may come in with a psychosis and bipolar. So bipolar symptoms, so the high highs and the low lows, the mania. So the difference here, so we'll talk about major depressive disorder and bipolar disorder in a minute, but there's a difference between schizoaffective and those two when it's a primary mood. So with schizoaffective, psychosis happens all the time. It's not contingent upon the mood symptoms. So psychosis is just present throughout. Now we have substance-induced psychotic disorders. In most cases, psychosis is short-term, but in rare cases, it may be after, especially after heavy and long-term use, it can cause the psychosis to last longer, so months or even years. This may be a result of marijuana use or methamphetamine use, and of course, hallucinogens. They may also have that effect. The next one is delusional disorder. This is just when there's a presence of one or more delusions for a month or longer. So except for the delusions and some behavioral ramifications, nothing else appears to be different. We also have psychotic disorders due to a general medical condition, such as brain tumors, infections, stroke, migraine, and some hormone disorders. And then the last two, of course, we also work with individuals who have primary mood, as I was saying, major depressive disorder, and bipolar disorder. So typically what happens here with psychotic features, I should mention, what happens here is that the person is having the psychotic symptoms, when they're having a depressive mood, for example, or a manic episode, I should say. So that's kind of what happens there. So we look at the diagnosis, of course, and then I'll talk about the criteria and what disorders we work with in our program in a little bit as well.
Okay, so we have a question too.
Sure.
Came in via text. So once you have, and it could be you or Dr. Frazzi, once you have the disorder of schizophrenia or schizoaffective, those are the longer term. Do you ever not have it? Do you ever, through therapy, or do you ever get better to where you're not, or are you just managing it like you would with diabetes or HIV? They're not the same, but it's kind of a chronic disease management. Are you ever cured?
So typically it is seen as something more chronic, although I have seen individuals who through treatment and some low antipsychotic doses, they may 100% recover and not have a lot of symptoms. Typically it's 5% of the individuals who come in may have no symptoms after the first episode. And the rest is kind of in between, where they may have some symptoms initially and then kind of fluctuate, kind of go up and down. And for 5% on the other end, you may have people who come in and they have symptoms 100% of the time. So it really is very, very personal. It's different for every single individual depending on their body and their experiences. I don't know if Dr. Bracey has anything else to say about that.
No, that's absolutely right. So we do see these as basically chronic conditions with no formal known cure. However, there have been reports and some experiences for folks, depending on what caused the underlying symptoms, where symptoms have gone away with treatment or they resolve. And it really is quite variable, but probably in general, the bulk of people will have to manage it, just like as that person said, something like diabetes or managing hypertension, something that may be seen as a more chronic condition.
Okay, we have two other questions. One, when you say it varies and some may have one episode and then never again, do you attribute that to the fact that they're treated and not cycling through many times of psychosis and causing organic brain damage?
Yeah, I mean, certainly I can jump in on that one, Gabby. The idea is that every time somebody goes through an episode of something like psychosis or severe depression or severe mania, that the theory is that there is some effect on the brain that makes it possibly either more likely to happen again in the future. So this is why a lot of research will say that depending on the number of episodes a person has experienced, the chances of another episode occurring later increase pretty significantly, pretty quickly. So yes, ultimately there could be, you would want to basically, and this is the idea behind, as Gabby will be talking about first episode treatment, is that you really want to reduce the number of episodes and also the length of an episode. I often talk with folks and say, listen, even if I did nothing, if you have depression, your depression is going to go away eventually, 90% of the time. However, let's try to get that to be as quick as possible, because that reduces the burden of suffering, but it also reduces this particular risk of, possibly lasting effects, or at least increased lasting risk for that person down the road.
Okay, we have one other quick question, and then the other one I think we'll get to in a few slides. But first, can a blast of steroids bring on a first episode?
That's a wonderful question. And so, yes, actually, high-dose steroids can cause manic symptoms, and in some people it has caused psychosis. And I have had some folks that I have worked with before, even way back in my training, who had those types of experiences. So it is possible. The good news is, for someone who goes through that, there's a pretty good chance with rigorous treatment that they can get that under control, and that maybe their chances of having further symptoms down the road would be much less. Obviously, they would want to know that. So if in the future they ever needed a dose of steroids, this could happen. For example, somebody with severe asthma. One of the people that I worked with very early in my training had a brain tumor, and every so often that person would need to go in and have intravenous steroids to shrink the tumor to reduce pressure on the brain during the different chemo and radiation treatments. And that would cause psychotic symptoms, usually hallucinations. So very good question.
Yeah. We have another one. Is there a higher risk of schizophrenia or psychosis that's attributed or correlated to race?
That's a very good question. So the international evidence shows that the incidence or prevalence of schizophrenia around the world, regardless of race or country or their GDP, is always about 1%. So it seems to be the same incidence and prevalence regardless of that particular person's ethnic, genetic, or even cultural background. Where you see differences is in things like anxiety and mood disorders usually. But a very good question.
Yeah. And we have a couple others that are tied to trauma that I think we'll get to. So let's go on to that, and we'll ask these other questions at the appropriate time.
Yeah, that's actually what we're getting to right now. So there's no specific cause yet that we know of for psychosis. It's a combination of genetic and environmental factors. We could even argue that it's 50-50. So people may have a genetic predisposition, and intense stress to the person and to the genes may trigger the psychosis. I went to a symposium about 3 years ago regarding psychosis, and it is 134 genes linked to psychosis. So I think this is part of the reason why psychosis looks so differently for every person. The idea is that everybody has those genes. We all have them. It's just some people's genes mutate and some people's don't. And again, it's just based on kind of the genetic predisposition as well. So to talk about the environmental factors, birth injuries may have an impact on some of the structural changes that happen during psychosis. So for example, if the baby is born with the umbilical cord tied around their neck, they may experience hypoxia. So they may be deprived of oxygen to their brain for a little bit, and that may actually cause some of the changes. Viruses, for example, as well. If the mom, for example, while pregnant is exposed to influenza, rubella, the mumps, that may also have an impact. Toxins like lead exposure. And there's also been a link to some herbal supplements and psychosis, like Ayurvedic herbs like ashwagandha, turmeric, cardamom, cumin, and licorice root. So there's usually just like a warning to pregnant mothers when they're taking these sorts of things, because there may be an impact. Famine as well. And we're not talking about, I just forgot to eat today. It's, people don't have access to nutrients, to food. So a vitamin D deficiency may also have an impact, and homocysteine, an amino acid in the blood, which you usually get from meat, it may be linked to some of the symptoms as well. Stress, prenatal stress, of course, depression in the mom, and loss when the mother is experiencing significant loss as well, that may have an impact. And when the person is going through sexual trauma, children of first-generation immigrants may be at higher risk as well when there's a genetic predisposition. Bullying and major social stressors like any transition, like from high school to college, for example. And of course, substance use can have an impact. What happens is that marijuana specifically increases dopamine levels in the brain. And we'll talk about it in a little bit, but there's a specific region in the brain where if you have hyperactivity of this neurotransmitter, the dopamine, that may cause the symptoms, that causes the symptoms. So that definitely may have an impact. And I was also reading about paternal age. So there's relative risk of schizophrenia. It reaches 3 times normal levels in offspring of men aged 50 or more, independent of the mother's age. So those are some of the things that may be linked to the symptoms. But again, we don't 100% know the reason yet. There's still research being done. So let's look at the changes in the brain really quick as well. So we have, can you click one more time? 2 times, actually. Thank you. So we have the mesolimbic pathway, and this is where the increased dopamine happens that creates the positive symptoms, hallucinations, delusions, and the changes to, oh my goodness, I kind of lost it. Let me go back. So we're looking at disorganized behavior and speech. Sorry about that. So when we look at the negative symptoms, the mesocortical pathway, when there's a decrease in dopamine, which is the longest one that you see on there, that blue line that's really long, that's the, when you have a decrease in dopamine, that's what may cause some of the negative symptoms that we observe in individuals as well. So now let's talk about the first episode, psychosis intervention. This is why we're all here. all of this can be what we just talked about. It can be very overwhelming for individuals and their loved ones. There's so much happening for someone experiencing their first episode of psychosis, and it's just very frightening time. People may not understand what's happening or why it's happening. So, their lives have dramatically changed and they don't know how to cope. So this is why it's so important to have people come into treatment as soon as they can. Thankfully, there's more research and treatment geared towards supporting and empowering people who are struggling with psychosis so that we can help build resilience and promote recovery. So again, it's looking at can you move 2 slides forward?
Okay, one question.
Sure.
When we're talking about structures in the brain, are these observable under any form of new technology? So new kind of scans, PET scans, other scans. Can you see differences in these structures?
Yeah.
Go ahead, Dr. Bracey.
Yeah, I mean, basically to jump in, yes, we can. Things like functional MRI, PET scans, as were mentioned. There are ways now with new advanced techniques where we can start to see these areas of the brain and how they're functioning compared to, say, somebody who does not present with those particular symptoms. So it's much more powerful now how we're able to look into the brain and see how it's functioning as compared to even, 15, 20 years ago.
Do you think that will lead to a test like you get a blood test to understand disease? Will we have tests that can look at the functioning and then more accurately say this is in the psychotic family, or this is maybe schizophrenia? We see this certain pattern or behavior.
Yeah, also a very good question. Eventually, I think the technology may get to that point where it's very likely. That's always been one of the big issues, is that we don't have a quick blood test or scan or x-ray you can do to diagnose psychiatric disorders. But yes, over time, if we can identify, and also as we learn more about what really is the underlying issue that results in people having psychotic symptoms, where's the lesion or the dysfunction or the area that may be different, say, than somebody who doesn't have those symptoms. And as Gabby has mentioned, there are probably many different roads to Rome in this regard, that there are a lot of different ways where you can see something in different regions of the brain, which gives you kind of the same look, which is one of the challenges is, you can have multiple different causes that present with the same symptoms.
Yeah. And here's one that you may want to answer or may not. It may be a whole different seminar, which we're going to do later in the year, but there's so much confusion about the use of marijuana. What is the current psychiatric recommendation for use of any type of marijuana products, CBD oils, or it seems like some people that have these diagnoses tend to like to do marijuana. Is that also contraindicated, or?
Yeah, so since my microphone's still off, I'll jump in on that one too, Gabby. Basically, as far as we know, it seems that adolescents are at very high risk for having psychotic symptoms with marijuana, not so much with adults. This is one area where a lot of folks are using either marijuana itself or the CBD oil that was mentioned as a treatment for things like PTSD, post-traumatic stress disorder. So there are people that are looking at this. However, there's really no good evidence. So we psychiatrists and others of us working in the field will say we don't really have anything that I can pull a journal article or a research study that says this is what the risks are or what the potential benefits are. But certainly people are telling us that they're trying these things, medical marijuana, for example. So what we usually do is talk with people is that if the person's definitely in adolescence and maybe even in the first half of their 20s, seems to be that they're at much higher risk of having psychotic symptoms. The other little caveat, and then I'll finish with that, is I think it's because a lot of the strains of cannabis that are engineered have much, much higher concentrations of the THC, the active component, than the old traditional marijuana that was just grown out in the wild or in someone's backyard or wherever. And the strains that have much higher concentrations, it's kind of like overdosing yourself on it. And so those probably have a much higher risk of psychosis than just the regular normal strains that have lower concentrations of that active component.
And one other question before we move on. Does psychosis occur in any other disorder than you already mentioned earlier?
So psychosis, and this is really drives home to Gabby's good point, is that it can be a symptom that can occur from a lot of different things. And Gabby really touched on it quite well. You know, you're looking at things like a mood disorder, you're looking at things like any of those, what we call primary psychotic disorders, but you also need to rule out things like influence of a substance, for example, methamphetamine, cocaine, the cannabis that we just talked about. You also want to look at medical causes. You know, is the person having some kind of a tumor, an abnormality in their electrolytes, the medications like the steroids we talked about, and thanks for your comments, Nicole. You know, certainly there are a lot of different things that can cause that, which is why it's so important to do a really good workup at the beginning to say, what's really causing these symptoms? Can we identify some other cause that should really be addressed rather than assuming it's psychiatric, starting treatment when maybe we're missing something.
Okay, well, thank you. Let's.
Yeah, so discussing the first episode, psychosis intervention, again, it's getting people into treatment as soon as we can. Early intervention is definitely key in recovery. Do you mind moving to the next slide? Thank you. So this is the critical period hypothesis. This is the idea that most of the functional deterioration occurs during this period, which is the acute phase of a psychosis. This is where we want to reduce the time of untreated psychosis. There's an idea as well that the severity of symptoms is predictive at this point, is predictive of the severity of symptoms later. So if somebody comes in with very severe symptoms, this is the right time to get the person into treatment so we can prevent some of the functional damage and foster recovery. And during this time also, this is when individuals show the best response to treatment, according to most of the research that we have for FEP services. So this is what we want, to get people into treatment right away. So let's look at our services, just so you have an idea of what we do as an agency. I'm moving to the next slide. Thank you. So typically, I mean, without focused care, let's focus on that. Without focused care, like the FEP programs, individuals who would qualify for the programs tend to bounce around from primary care, emergency rooms, and just general mental health counselors for months and sometimes even years. So I look back and I think of myself as a therapist, a general mental health therapist before I worked in the FEP program, working with individuals who have psychosis. While I had the best intentions, I did not have the appropriate tools at all to really assist the way that, you know, people deserve to be assisted in the process. And I can think of a specific person right now that I've been working with, who was bounced around from hospital to hospital for almost 2 years, landed in SMI services as a result. And when this person got to our program, no one had ever explained anything about his illness and that coping was possible. He had no idea what was going on. So acting quickly to connect a person to the right treatment during early psychosis can really be life-changing and radically alter the person's future. So we want at least 18 to 24 months of treatment. This doesn't mean that if a person is, you know, they've got to the 24 months, we're going to kick them out because we're done. You know, people typically may benefit from other services as well after that, after the 24 months, but at least we would like 18 to 24 months. We have different components as part of treatment. We have psychotherapy, so this may be individual or group. We have family support and education, medication management, of course, supported education and employment, which is very important, peer support and case management services. And our approach is a coordinated specialty care approach. So this speaks to a team. We have a team of individuals working with people who are affected by psychosis. And this is what most FAP programs have identified as evidence-based treatment, to have a coordinated specialty care approach. So let's look at that a little bit closer in the next slide.
And
Thank
one
you.
question too that
Sure.
came in, for those people that weren't fortunate enough to come across first episode treatment centers, so it was missed or they were guarded or they didn't believe they were ill, if they have had multiple periods of psychosis and they've had this for years, what can they hope to do? What's out there for them if they've missed this form of treatment?
Based on the research that we have, for people who missed that opportunity, for example, general mental health works as the same as the FEP program would, based on the experiences that they've had. But I mean, they could definitely benefit from the the tools that we offer as well. But for the most part, we work with people who have the first episode psychosis. So it's working on managing a lot of the times. I don't know if Dr. Bracey has anything else to say about that piece.
Sure. I mean, this is one thing that we really believe in, and the evidence shows is that the brain is very what we call plastic, which means it has plasticity. It can always grow, change, and adapt. Yes, it's faster to do so when the person's very young. However, basically, as long as you're upright and breathing, or even if you're horizontal and breathing, the person still has the ability to change. And so this is what's really important is that it's never too late. It may be a little bit more difficult, but at the same time, progress can still happen. So, that's why we try to jump in as Gabby's discussing this program as early as possible, because really we just want to reduce the burden of suffering that somebody might be going through as soon as possible in their life so that they can move forward and pursue the meaning and purpose that they want out of their life.
Yeah, and currently I'm actually working with a couple individuals right now who have had the disorder for a longer period of time, and I do see the benefit of continuing treatment and introducing some of the techniques that we use with early psychosis. I hear some feedback.
Yeah, I'm trying to mute that person.
Okay, so let's look at what coordinated specialty care is. So again, it's a team. We work with a team of individuals. Currently, we have 3 therapists, including myself. We have a lead clinician. We have a case manager. We have obviously Dr. Bracey on the team. We have an outreach specialist, and we will be having supported employment and education person coming on board, and a peer support individual as well.
Okay, next slide.
Sorry, I was muted for a second. Okay. Can you hear me?
Yes.
Okay, perfect. I don't know if you missed anything because for a second it was muted. Can we move on to the next slide, the shared decision-making slide?
So are we going too fast? Are we beyond?
It would be slide 14.
Oh, okay, sorry about that.
Yeah, no worries.
This is 14, so maybe 15.
Yes. Yes, so that one, yes. That's the coordinated specialty care. So it's the idea that we are working with a team. It takes a village, right? So it's all about collaboration and shared decision-making with the participant and their family members at the center of the team. So basically, it's just knowing that the participants are their own experts. I may have tools, I may have different approaches that I can bring to the table, but, the person is their own expert. They have an innate ability to recover, build resilience, and thrive. So we're looking at their strengths, abilities to foster recovery. Our job here is to increase knowledge, increase participation and commitment in treatment, and strengthen the therapeutic alliance. We have a menu of options to offer, but I could even argue that the therapeutic relationship is one of the most important things that we have as a tool for treatment. So our job here is to strive to be completely attuned to the needs of each individual. So let's move on to the next slide really quick.
Okay.
So we can look at who qualifies for the FEP program. So we have the age range is 15 to 30 years old, and people would come in within the first 2 years of their first psychotic episode. And we usually work with people in the schizophrenia spectrum disorders and primary mood with psychotic features. So now we can look at the exclusionary criteria as well. And this is all based on the research that we have as well, how we decided our criteria. People who don't qualify, it's anybody who's outside the age range of 15 to 30, anybody who's coming in with a substance or trauma-induced psychosis. However, this does not mean that if somebody comes in with these difficulties that we won't see them. We can still work with the individuals and offer most of the same treatment. They just won't be a part of the specific program, the FEP program. People who have cognitive delays, organic brain impairments, autism spectrum disorder, or a traumatic brain injury, a TBI, for these individuals, they require specialized treatment that we don't offer with FEP. So what we would do is work toward making appropriate referrals for services for them.
Okay, we did have a question, one of which is the state hospital, Arizona State Hospital, aware of the treatment involved with this. I would think, but you guys can jump in, that by the time they're at Arizona State Hospital, they probably not qualify for this any longer, but I don't know.
Yeah, I mean, to jump in, basically by the time somebody has been admitted to the state hospital, they usually have a long journey where they've had multiple attempts at treatment, including multiple hospitalizations. So they would not, they probably have an awareness of FEP, although I would doubt that they would have an FEP program because of the limitations in really the population that they focus on and serve.
And they also wanted to know, Dr. Razi, if you do outside consultations.
Well, our organization does take referrals. We do treat people. I saw the question was about either children's through adult. There's myself. There are also a cadre. We have 3 additional psychiatric nurse practitioners. Dr. Nicole Lyons, who's on, is our acute care and primary care doctorate of nurse practice, who's our medical director at our site in the East Valley. And I also have a physician assistant who is assisting us with doing MAT, medication-assisted treatment. So we're actually starting up a program where we can do induction or starting buprenorphine for folks with opioid use disorders, or also continuing their buprenorphine as a maintenance treatment, which we can do across several of our clinics. The inductions, however, will only be at our Northern Avenue and 23rd Avenue location currently.
And then I'm not sure if you want to address this now or later, but the question is, why is there no national approach to treating serious mental illness, like in breast cancer, for instance? Oh, and it moved. There is generally a national practice that doctors can refer to best practices, and SMI, where is there a hodgepodge approach, and why?
Yeah, it's a very interesting question, and I think ultimately the answer to that is because there is actually nationally accepted standards on the treatment of people with serious mental illness or psychosis in this case. The difference is that each state makes its own determination with their public health service about how they're going to structure those services, what they're going to fund or not fund. This is why you see such a difference, is that each state does their own thing. And so some states have really, depending on who's in charge of their public health department or the people, the health plans who are involved, They may have different experiences or ideas, and also looking at their own individual population, they may see that there's some unique needs for that. So each state really makes a good faith effort to try with the budget that they have to do the best that they can. But yes, this is why I think you're going to see quite a variability from place to place. The general standards, though, that usually come out are nationally adopted. So for example, in my specialty, the American Psychiatric Association will publish guidelines and research so that we're all on really the same boat. Additionally, to be board certified like myself, you have to pass examinations and also really demonstrate your understanding of what are those generally accepted standards. There's a lot of variability, though, in those things. And often you'll hear that phrase that medicine is also an art as well as a science. And I think that really speaks to there's a lot that we still need to learn about the brain. This is also why you might see some variability. So if you're finding in your community that you're frustrated with, for example, the services that are offered, often really feeding back that information to health plans, to providers, and also to your politicians can be a really powerful way to advocate for people who are suffering.
And the last one before we move on is when you're, let's say your child has anosognosia where they don't have any insight, then we have a lot of roadblocks into care, right? So that's been this person's experience, and others, they wish treatment doctors could band together to educate and promote compassionate and voluntary treatment. Because sometimes if someone doesn't know, then they start this cycling and they miss out on first episode. Parents are fighting all the time. It occurs in the hospital with other diseases. Psychosis has unique features that can compromise decision-making ability. It's usually a temporary condition, just like mask wearing, yet the disability groups, the ACLU, continually fight to loosening those laws, which can possibly help save your loved one's brains. Any thoughts, Dr. Krause?
Yeah, that's obviously a very important sort of ethical discussion. Now, it's very interesting because when I worked overseas in New Zealand, there were some experts who came from Spain and were doing a sort of a roadshow and talking down there. So for example, in Spain, they don't have involuntary treatment because the families are empowered to really be actively participating and involved. The healthcare sector there really involves the family and respects their input. And so they don't need things like unforced treatment or court orders because they're often able to wrap around the person and support them through those episodes. It's going to be different for each culture, of course, and I'm not advocating that that's what we necessarily should do here because I'm not an expert in the legal field. But from an ethical standpoint, this really gets to that point that the sooner you can get in person involved in some care to help them, then the better the outcome. And this is the idea behind FEP. When it comes to then dealing with developmental disabilities or genetic disabilities or medical issues, this does complicate things because then it's not necessarily very straightforward. What's the path out? And so often getting the full team, including the family, the medical team, and the person involved to try to get together as a team and figure out what's the best path. That's why it's so critical at those points. So I'm sorry, I don't have an easy answer for that, but I definitely sympathize with the struggles. This is, hard for people, and these are sometimes not easy situations or questions at all.
Would you support, or do you think that the American Psychiatric Association supports the idea of reclassifying the mental illnesses as brain disorders, some of them?
There, certainly the idea is that when you look at the information or the research out of the American Psychiatric Association and the affiliated, universities and scientific groups, is really the belief is that mental illness is frequently seen as some kind of dysfunction in the nervous system. So it's really seen as a disorder. However, there has been some controversy. Do you simply tell somebody, hey, you've got a chemical imbalance and that's it? Does that just reduce the person then and their experiences and what they're going through and their suffering in some way? Or on the other hand, does it actually reassure the person like, hey, just like I've got high blood pressure, or maybe, I have a broken arm, I just have an issue that I need to address and get some help with. So I think it has to be quite individual for each person because we're dealing with feelings and perception and thoughts and spirituality more so than just a pure physical thing. So I think it also really speaks to, as I mentioned earlier, that the brain is very complex. Like this is probably the most complex organ we have in the body. And there's still a lot we have to learn. And this is why you see historically there has been all these efforts to really expand our knowledge about how do we view these types of things that people go through and what are the things that we can do to support and help them.
Thank you. Okay. There we go.
Thank you so much. Let's look at our psychosocial treatments, the things that we do have to offer. So first and foremost, our approach is always person-centered. And when I say person-centered, I mean person-centered. When someone comes in feeling confused, hopeless, defeated, what we do is we hold the hope for them until they're able to take it back. We believe in the person's ability to build resilience and recover. We have a menu of options and the person decides what works for them and what doesn't. The way I like to think about it, and I usually tell people this, we're the navigation system, but they're driving the car. So if at any point they need to stop or if they need to take it slower, if they need to go faster, that's what we do. If they need to take a turn, that's what we do. I had an individual, for example, I've been working with her for about 2 years now. So the first year,
Just a minute. My gosh.
her attention was just very, very spotty. And I just refused to close her case. I mean, another case, we would have done that, but I refused to close her case because I knew she was grieving. I knew she was angry. So we just met where she was. Sometimes I would talk to her about just random things that had nothing to do with the illness or recovery or anything. And eventually, once she was able to process some of the grief and the anger, she was able to come into treatment more often. And we're still working together. She's even thinking about employment at this point. So we just meet people where they are. That's just it. Some people come in and they don't want to talk about their illness. They don't want to talk about their symptoms. So we talk about whatever, their games, whatever games they're playing, whatever songs they're listening to. It's just getting to know the person. And that's really, really what works. So we have, as part of the program that we adopted, part of the RACE model and from On Track New York, we have 10 core sessions that we use. And these sessions may be done in different order, depending on where the person is, of course. The first meeting typically is just the introduction to the FEP services, the team, and what we do. We may answer some questions here. And I think it's one of the most important meetings, actually, because this is how we're engaging the person in the treatment. The second session is about just early intervention and recovery. So we try to understand and explore what the person is going through in these during this session, what their experience is with psychosis. So we also talk about what an early intervention looks like and what recovery may look like as well. The third one is shared decision-making and treatment goals. So we look at what the recovery goals are. And this may happen right after the first meeting or even in the first meeting. So we're identifying what needs to happen here in treatment, what they need, what they want, and so on. And number 4, we typically explore cultural background, just very, very important, how the individual and their family understand psychosis. For example, we had a person one time, or several people actually come in and they've had exorcisms because of the symptoms. So we need to know that. We need to know that so that we can educate and we can work with the family in the best way possible, keeping in mind their cultural beliefs and religious beliefs and so on. We also work to, number 5, we work to identify strengths and social support. So we usually have this question when we do the assessment and people come in and sometimes they don't know what to say when you ask, what are your strengths? And people are like, I don't know, I don't think I have any. So our job here is to pull those strengths, to notice what people are coming to the table with. Everybody has strengths. So that's what we need to know here, and use those strengths to help people move forward in their recovery. And also connect people with social supports, best friends or family members, educating their family members so they can also be social supports to the individual. 6 and 7 are typically optional, depending on the person, what they need. So enhancing social skills is one of them. So if a person is having trouble socializing, connecting with others, we do that in that session. We try to model, we do role-playing sessions where we model what it looks like to have a healthy relationship. We work on social networking, dating, what that looks like, expressing themselves, regulating emotions, demonstrating appropriate boundaries, and responding to social cues. Just communication skills is what we do there. And number 7 is understanding how substance affects recovery. And this is specifically for people who are using substances, but I tend to just talk to everybody about it either way, just in case. We want to educate on how the impact of marijuana and other substances and how that affects the person. I have seen individuals who they just tried it. They just wanted to try it just to see what it was like to smoke marijuana. And typically symptoms may return when that happens. So I just educate either way. Number 8 is learning to manage emotions and symptoms. Sometimes this may actually be one of the first sessions we have. People come in and they're like, I just don't know what to do with this now. So we work on managing, building skills just to manage what works for the person. We have a list of coping skills specifically for auditory hallucinations. So we go through the list and then we figure out what works for the person. We also look at emotion and grief, what to do when you're so angry, what to do when you're so anxious and just depressed. So we look at those things as well during that time. And again, sometimes that may be one of the first sessions that we have. Number 9 is increased engagement in the community. As I was saying earlier, when you introduce antipsychotics, people may not have the positive symptoms anymore, but they still have some of the negative. So our job here, number 9, is being able to get people motivated, moving, doing something. Recovery doesn't happen when we're idle, right? So we need to do something to achieve that. So it's being maybe working, going back to school, helping people in school when they're struggling, just maybe getting more involved in the community. Typically we'll refer to groups. We have groups here as well, so we can do that during that time. And then the last one is transition. And this happens again throughout the 2 years that we're working with people. Transition, we start planning for that 6 months before at least. And this is when we are connecting people with community supports more often than not. So this doesn't mean that if a person is, they came up to the 2 years, we're not going to kick anybody out. This may just look like a step down. They may not be part of the FEP program, but they may be part of the general mental health programs that we offer to you. They may also just be doing medication management. Maybe they're not doing any more psychosocial stuff. They may also work on just processing trauma or whatever they need at that point. So we don't just drop people, we try to transition, and it's a team effort. We don't just decide, okay, yeah, you're done. They have to also be part of that process. So now let's look at some of the interventions that we have. Moving on to the next slide. So cognitive behavioral therapy is an evidence-based treatment for individuals with psychotic disorders. And there's demonstrated efficacy in both individual and group formats. So the idea here, or what the whole theory of therapy suggests, is that how you feel, you think, and act. So you can see the cycle right there. Something happens. For example, people are having symptoms. Now they have this, disorder. They have psychosis, and they're dealing with, schizophrenia, schizoaffective, whatever it is. And now they're thinking, that's the event. Now they have symptoms, and now they're thinking, I'm broken. I'm permanently damaged. So what happens is that because they're thinking that about themselves, now they're feeling sad, they're feeling angry, they're feeling ashamed, anxious. So when they're feeling that way, what they do is they start isolating, they withdraw, they do nothing. So when they do nothing, they go back to, see, told you, I'm broken, I'm damaged, I can't do anything. Our job here is to challenge those negative beliefs and really look at the reality. Yeah, they're dealing with something, but that doesn't mean you're broken. So it's typically what I do is I look at, okay, what negative things are you thinking about yourself in this moment? How does it impact your behavior, your emotions? And what is the truth? Who are you when you think those things about yourself? And who would you like to be? Who do you want to become when you think the opposite? Or who do you become when you think the opposite? That you are worthy, that you're good enough, that you're okay the way you are. So we look at just challenging those negative beliefs. We can use it for anxiety as well. So we can treat the comorbid disorders as well. So people may come in with a psychosis, but they also have anxiety. They also have depression. So we can use that for that as well. And we use it in conjunction with the next one, which is the cognitive remediation. So cognitive remediation is something that we adopted from the previous model we had, what we call the Brightboard model, but it's after a race, the race initiative. So we have computerized, so it's called metacognitive therapy. It's computerized exercises, the repetitive, and we offer this to address the cognitive issues that people experience. So this is, for example, I'm trying to think, it covers different areas. It tries to improve the visual spatial abilities, memory, problem solving abilities, and we usually go through 8 modules. We do this throughout the first year if people are interested and they can benefit from it, because not everybody comes in with cognitive deficit. But if people do come in with that and they want this sort of treatment, it usually spans about a year. And we have 8 modules that we go through. Foundations 1 and 2, which is typically geared towards just attention and focus and part of memory. Then we go into visual spatial 1 and 2, memory 1 and 2, and then problem solving 1 and 2 at the end. So it starts with testing. The person comes in, we do a test, a cognitive test. It's called the Matrix Consensus Cognitive Battery. It contains 10 tests, and we're testing 7 areas. So visual learning, verbal learning, working memory, which is what we just hold information temporarily for reasoning and decision-making behavior, processing speed, social cognition, attention, vigilance, and reasoning and problem solving. Those are the things that we do in this part of the treatment. So the person comes in, we do the test, then we do 6 months of metacognitive therapy. Then we do another test just to see progress on how that's going. And then another 6 months, and then a test at the end, just to see where the person is and the changes that we're observing.
Gabby?
Yeah, go ahead.
Or Dr. Brasi? So for this, are you waiting until the psychosis is gone? I mean, if someone's in active psychosis, you're not testing them then. You get that taken care of and then start this portion? Or
Yes, typically that's the way it starts. Depends on the individual. We have had people who come in and they have symptoms and they're actively experiencing positive symptoms and they're able to do it. But then for some people, we have to first manage the positive symptoms and then start working on the metacognitive therapy.
And there was another question. Are there patients who do not possess the insight to participate and do not trust family or doctors? And what is recommended when that occurs?
Ooh, that's a good question. Yes, sometimes that happens where people come in and they're not trusting anybody. I actually had a participant come in once and they just did not want to. We tried doing the intake. We tried working with him many different ways, just did not want to. Eventually they ended up leaving. That's a really hard one. I don't know if Dr. Bracy has any other ideas about what to do when that
Yeah,
happens.
and it's an excellent question because often families will come, ooh, feedback. So my microphone seems to be okay. Families will often come to us, and pretty stressed out and saying, gosh, help. And, the hope is that somehow we can very quickly and swiftly get the person to say, now I will comply. I will suddenly understand that there's a problem. And sometimes where they're at is not there yet. Often what I do in my approach with people is I try to really work with them and say, listen, my job's not to tell you right now what's real or not, because you're not going to trust. I don't say this part, you're not going to trust my opinion because you think I'm part of them that's trying to tell me I'm sick when I know that this is a problem. So really it's trying to teach the person or work with them to say, however, regardless of what's real or not, you're suffering, you're stressed out, you're not happy. Can I at least support you with that? Can I help support you with, because if somebody thinks that they're in danger or suffering from paranoid thoughts, they're going to be pretty stressed like anybody would be. So we try to at least build some rapport. And also, if you look a lot of the FEP models, they talk about rather than sitting there and trying to get into a power struggle, is to say, what are your goals? What are your strengths? What is your purpose in life? And trying to align with that, because through there, we can start to build that rapport, we can build the relationship, and then hopefully they will stick around, that maybe over time they might start to say, okay, now I'm actually willing to look at this. Let's take it. But we have to go at their speed. And we obviously, if things are in a dangerous situation where there's risk of harm to self or others imminently, then yes, sometimes we have to jump in and really provide safety for that person immediately. But aside from that, then we often try to educate families, as stressful and scary as this is, let's be patient, let's work together, and then try to get that person on board at the speed at which they can do it. It's kind of respecting their approach really in that way. So, but a very good question. It's a tough one. There are no easy answers. And so really this is one field in healthcare where often the relationship between providers like Gabby and myself is more adversarial. If you go to the doctor for a cold, you're like, thank you, doctor or nurse practitioner or PA for helping me. Sometimes we get into situations where the person really doesn't want to be seeing us in the first place. And that's tough.
Yeah, right now I actually do have 2 individuals who came in reluctant completely to participate in the program, and just connecting, as Dr. Brazy was saying, like, hey, you're pretty unhappy, let's work on something else. What do you want to work on? And they stuck around and we're still working together. So it just depends. We really try to engage as much as we can. So thank you for that question. So back to the cognitive remediation. So a metacognition, so it's metacognitive therapy. A metacognition is a thought about a thought. So as people are doing the computerized exercises, they're thinking about how they're doing those exercises. So it's basically developing skills that they can use outside in the quote unquote real world. So that's what we're using there. And we're constantly monitoring arousal, emotional regulation, and self-efficacy. So if they're too anxious, then we work on kind of regulating that. If they're too bored or too flat, then we look at that as well. And self-efficacy, that's where we use the cognitive remediation and the CBT in conjunction. If somebody is doing not so well in an exercise, then they're thinking, oh, I'm so stupid. So then we work through those beliefs as well. This is a really good tool, especially in the beginning when people don't want to talk or they don't want to be here. This is a really, really good tool to utilize. And eventually people start talking. I had a participant who was dealing with that initially, came in and just refused to talk, was very angry, would have bad exercises, for example, and then would start banging on the table and just upset. And through working, through those exercises, it's been 2 years now, and this participant is doing so well. He's back in school, and feeling a lot better about himself, and just it's just fantastic to watch that happen. So moving forward to the other treatment approaches, this is our menu that we have. We have many different things that we offer. Larry was talking about the polyvagal theory. It's basically the lens through which we see people as they're coming into our services. This looks at how the nervous system responds to danger, safety, and life threat using 3 survival states. It helps us understand our automatic responses and helps us cope and build resilience. So we're constantly acting out of survival, and it helps decrease shame in how we behave. So there's something that we talk to people about. We have different exercises to help people recognize their states and kind of work through that and be able to regulate much more effectively. We also have the Safe and Sound protocol, and this is therapy using music. This targets the middle ear muscles and improves safety in the body. So this requires 5 sessions it's for an hour of just music. It's a playlist of regular music. It's just filtered in a way that it targets the middle ear muscle. And it helps kind of decrease therapy time in the way that it helps improve safety a lot faster. We also offer motivational interviewing. It's something that we use constantly with people who are having trouble just kind of participating sometimes. This is a directive, client-centered, and focused. It's a client-centered approach, and it's focused on eliciting behavior change by helping the client explore and resolve ambivalence. So when they're trying to make changes, but they're not sure yet, we try to elicit change talk, is what we call it. So we use that as well, especially for people who are having trouble taking their medication. They don't want to comply with that piece of it. We work on that as well. Now we're also offering EMDR therapy, which is something that helps process trauma using eye movements. We look at grief and loss. This is a really, really, really big piece. Just looking at when a person's coming in and they've lost their health, they've lost their life the way they knew it. So this is a really, really big one. People don't want to talk about it. People don't want to hear the word psychosis. They don't want to hear about the symptoms. They're angry, they're struggling, they're having all these symptoms, all the grief because of their, they lost their health, their mental health. So we really look at this piece. There's a group that we offer as well for that. I run that group, in fact, although it's mostly for adults. We also offer psychoeducation, and this is for families and of course for the person who's coming in and in recovery. We have skills training, and this could be done individually or in group. So this is for anything that the person needs: independent living skills, writing a letter, how to write a check, finances, managing time, socialization, managing emotions, anything that we can help in that, and just skills, just learning skills overall. We also have a group therapy, and we have an FEP adolescent group. So this is ages 15 to 19 if they're still in high school. And this is a CBT focused group. It focuses on health and wellness, processing, skills training, and just managing symptoms overall. Then there's also the FEP young adult group. This is 19 to 26 years old. And it's the same thing. It's just kind of processing whatever's happening, socializing, and just connecting with other people who are maybe going through the same thing. And then I run a multifamily group. This is part of the family support that we have. I run a multifamily group every 2 weeks in English and Spanish. So this again is for psychoeducation, just helping parents understand what their kids are going through, offering support for parents, problem solving, parenting skills, and anything that the person needs. We also have other groups as well that people can participate in, like self-empowerment. We have Art Awakenings that people really benefit from as well. And we try to refer everywhere the person, wherever the person benefits from, we try to do that. So let's see if we move on to the next slide. So the most important thing that helps people recover, again, we have a a menu of options, but really what helps people recover is getting active. Passively sitting around waiting for medicine and professionals to cure you, it's not the way to recovery. People need to be active by participating in treatment, for example, providing honest feedback about what works and what doesn't, focusing on personal goals, building goals, having something that you're looking forward to, big or small. And if there's something that seems really overwhelming, then we break it down into smaller pieces. Finding support, educating friends, family, and then just coaching others is something that I talk about a lot in therapy. Sometimes your family members may not know what to do. People around you don't know how to work with you. So then it's coaching other people as well. What do you need from them? I typically ask that question, what do you need today? And it's a simple question, but it's a very, very important one, because it's the idea that people know exactly what they need when they need it. So it's part of the finding support there. Developing structure, very important too. So having something to do. Typically, people who are isolated and idle, they have a lot more symptoms. So it's getting busy, doing something, coming to treatment, going to groups, going to school, going back to work. All of those things are very important, staying active. And of course, addressing drug and alcohol use and taking care of oneself, making sure that you're attending appointments, eating right, exercising, sleeping. Sleeping is very important. There was a participant coming in one day saying, I'm doing everything right, but I'm still having a lot of symptoms. And it turns out, if they're exploring a little bit, she wasn't sleeping. So that was adding to some of the symptoms. So it's just being very, very active in treatment that really, really helps.
So
And then
a question,
go ahead.
kind of a comment. So
Sure.
both of you are under of the belief system that just taking a pill is not going to save you. You need to kind of build a life, right? It takes more than just the medicine.
Yeah, definitely. It's being active. It's not just the medication, but then also using other skills and connecting with other people. Being social is very important in the recovery process. Just connecting with other people in general. I mean, just for every single one of us, psychosis or not, just connecting with people is very important. So yeah, being active, very important in conjunction with the medication.
So during these times of COVID, when a lot of groups and a lot of areas and gyms and everything else are closed down, what do you suggest now when people aren't gathering as much and people maybe are isolating due to COVID or fear or all of the above?
So social media is a really big piece right now. I have a lot of participants who are working, just connecting with their friends on social media, and Snapchat. There's a lot of that going on right now. We have groups right now on telehealth as well. So we're still connecting with people in that form. We do have some groups in person when they're small. Everybody's wearing masks. We're making sure we're 6 feet apart. But we still have ways of connecting. And, through social media, people can just, call someone, write someone even. So that's still pretty important. Reaching out to your loved ones. If you have somebody who's struggling with psychosis, reach out to them, talk to them. All of that is very important, especially during these times.
Thank you. Okay.
And then I'll turn it over to Dr. Bracy for the pharmacological piece.
Right, so this ties in really well with the question about medication. And yes, I mean, medication is a tool. So I often describe it as a scaffold or a support for people as they go through their journey, with the goal eventually, if we can, it would be wonderful to either minimize and reduce the doses of medicine, or in some people, they're able to do without medication for extended periods. So we certainly don't want to give them the impression, well, all it is take pills, go home. That's sort of a very disempowering approach, because ultimately it tells the person, it's the pill that's fixing you. You can't do anything for yourself. And that's not true. The pill is a support. Just like if you have a big cast on your leg, some crutches are going to help you. ambulate until you don't need the cast anymore. So this is the goal we always strive for, is that maybe the medicine is the assistant that you may or may not need anymore, or what you need or what you benefit from may fluctuate or change quite a bit. So when we're looking at, and we're talking about just psychosis here, of course, obviously there's a lot of different medications that are used for different types of symptoms, concerns, presentations. It's the antipsychotics, as we call them, or the medications that have the evidence base for use in first episode as well as other types of psychosis. The idea is that we want to, as it says on this slide, try to stabilize levels of brain neurotransmitters. These are the chemicals that the brain makes to communicate. So if you think about it, your brain cells actually physically don't touch each other. There's a tiny, tiny gap between billions and billions of brain neurons or nerve cells. And so what happens is that the brain cells have to communicate. They have to be able to talk to each other. And so neurotransmitters are like little FedEx delivery packages that go from cell A to cell B to send this message. So the theory is that, is there somehow too much or too little of a particular neurotransmitter in a particular region of the brain? Now, this can be whether you are dealing with, psychosis due to substances, whether you're dealing with some horrible experience the person has gone through, stresses, or it just seems to be maybe genetically related. That regardless of the cause, we can see that there tends to be these fluctuations or possible changes. The question, the $64,000 question is, as most of you know, the predominant or primary theory has been the dopamine hypothesis. This has been around since probably at least the 70s. The theory is that there is too much dopamine in the brain, and therefore the person has these positive symptoms that Gabby talked about, hallucinations and delusions primarily. That if we lower dopamine levels in those regions of the brain, those particular things go away. Dopamine also is, however, used in things like your drive, your motivation, your sense of enjoyment, and it's also used in things like your motor activity. People with Parkinson's, right? They have too little dopamine and they start to get rigidity and tightness, or cogwheeling as we call. And you see their face starts to really flatten and not show much emotion. And so dopamine is used throughout the nervous system for many different things. This, by the way, is why medications can give you a lot of unwanted side effects, because it affects everything, not just one area. This is sort of the holy grail that researchers are looking at. Can we find what really helps the person with their symptoms without crossing over into all these other areas, like the motor stuff, where we get the effects we don't want? The side effects also, as you can see at the bottom of the screen, are ones that people are pretty familiar with. And there's the constant search for medicines that will not cause so much weight gain, or increased cholesterol, or increased glucose, where people end up having diabetes. The drug companies initially were stating, well, people with schizophrenia have a higher rate of diabetes than people who do not. And that may be true to some extent, but it doesn't get away from the point that the medications are well known to be potentially causing things like what we call that metabolic syndrome, which is basically diabetes. Also, you can see the abnormal movements, long-term use of antipsychotics. I just mentioned how dopamine is used in the muscles, motor control. People can get this thing called tardive dyskinesia, which is sort of abnormal movements, which almost look like a form to some people of writhing or changing, where that may occur really anywhere in the face, the lips, the tongue, neck, torso, arms, or legs. It is not a dangerous condition, but gosh, it would be pretty darn frustrating to have. There are newer medicines out that actually stop that in a safe and effective way. Unfortunately, they're still under their initial patent, so they're very expensive and difficult to get outside of those who can afford it in the private sector. Obviously, over time, as those patents expire and maybe other people develop other alternatives, that may broaden the competition and drive prices down so that everybody gets a chance to benefit from them, if that's what occurs in their experience. We also look at blood cell counts. So this is where sometimes you may hear about with medications, especially clozapine, that we look at if it lowers your white blood cells, which are your immune cells. That can also be a concern. And this is something that we can monitor. If you catch it early and stop, switch to something different, then the outcomes are usually quite good. but it does require monitoring, including lab work and also baseline EKGs, where we're checking the heart rhythm. Sometimes some of the medicines can affect that in people who have pre-existing heart disease. So the medicines have their dangers, but they also can be lifesavers for people. And this is why it requires a team who really is engaging with the person, monitoring with them, and making sure they're not taking more medicine than is really necessary. As you can see in the big red circle, the last comment I'll have on the slide is that in first episode psychosis, there is a pretty massive push in evidence that shows that for young folks, if they are interested and willing, long-acting injectable antipsychotics might actually be better. Number one, you get smoother blood levels. Instead of up and down with your pills, the blood level goes up and is flatter through that month. They have less side effects, therefore. And also, if they're out with friends, if they want to stay over at someone's house, instead of explaining to their friends why they have a bottle of this pill or these pills that they're taking, they can just go to the clinic, get a shot every 1 or even every 3 months, much more discreet, and it gives them a lot more flexibility in their lifestyle, assuming that they want to do that and that they feel safe with it. And
Dr.
yes.
Okay, so that's good for the psychosis. If they're schizoaffective and they have the mood disorder as well, are there any shots on the horizon that can handle the mood disorder along with the psychotic disorder so they don't have to continue with the orals?
Very good question. And actually, these newer injectables also are indicated for depression and bipolar disorder. So yes, any of the newer injections have mood stabilizing properties so that the person can get the benefit for everything. And I have some folks who have a bipolar disorder, for example, with psychosis, who are on long-acting injectables and doing really well on them. I'm very happy with that. A couple of the folks go to the clinic where Gabby and I are at, so she would know who they are. So that's the good news. The old medicines, not so much, but yes, with the new stuff now, you do have that opportunity, which is nice. So I think we look at the next slide. This is really just a list of the first and second generation antipsychotics. Really the main difference is that the first generation antipsychotics really focused on dopamine. Now there's controversy about whether the dopamine hypothesis is really the most accurate. What about things like serotonin or norepinephrine, or, what about all this, people are doing ketamine for depression. What does that mean? NMDA receptors. There's still a lot that we're teasing out and trying to learn. But what we do know in the evidence is that these second generation antipsychotics, they also have big effects at serotonin. And because they work at serotonin and dopamine, as well as norepinephrine, we seem to have better success with folks with a lot of the symptoms that they complain about. The old original one was clozapine, but as many know, it has a lot of side effects. Weight gain is a big one. And you also have to do the blood test because it really can drop the white blood cells in some people. Not common, but when it happens, it has to be catched early on. The other ones, some of them are associated with a lot of weight gain. Others are actually really good for not causing weight gain. But you have to find what works best for each person based on their genetics and their chemistry. So I think that's it for that slide. And that just gives you an overview of some of the frequent ones that are out there. And I'll return this section over to you, Gabby.
Oh, I'm still muted. Sorry about that. So yeah, some of the benefits that we can see after people go through the services for FEP, definitely a decrease in symptoms and hospitalizations as well, reduction in substance use, decrease in psychotropic medications as well. Sometimes people don't have to take, huge dosages of the medication. Improved relationship. This is a really, really big piece. There's an improvement in cognitive function, especially if they're using the metacognitive therapy. Reintegration into the community. I have a lot of participants right now going back to school, trying to get to their GED, finishing school. A lot of my participants that I had last year, they graduated high school already, which is really, really awesome. So again, returning to work or school, and more connections with the outside world, people looking into maybe volunteering, helping other people as well. Now let's look at some of the people that I've, moving on to the next slide, a testimonial. This person actually worked with my colleague, the lead clinician, At first, before the FEP program, he was having trouble with school and work during because of the symptoms. It was just really difficult hearing the command hallucinations. This person had really low motivation, multiple hospitalizations, and tons of suicidal thoughts. After the FEP program, or during the FEP program even, there was only one short hospital stay. The person was able to go back to part-time work and just to kind of cover his expenses, graduated from ASU with a bachelor's degree in business and was able to start his career, which was really, really cool. My colleague recently actually got a phone call from him just to kind of catch up and say that life is going pretty well.
That's very cool.
Yeah, it really was. I worked with this individual, age 23. He entered the program. He was actually my first participant when I started working in this program. He came in with severe social anxiety and psychotic symptoms. So after the program, he was able to get a part-time job. He was attending college. He was going full-time. I believe he graduated this year. He was living independently with increased socialization, seeing his family and friends more often. And he was saying that much of the progress he made was because of the FEP program. He was doing the metacognitive therapy, and he finished the whole entire thing and was just doing really well. I also have right now a 17-year-old male who stopped using marijuana, increased socialization. He's more open and honest with his family, building friendships. He was ambivalent about college. He's decided to go now, and the symptoms are still present, but are much, much more manageable. Another person, 18-year-old female, very angry and rebellious, fighting in school, having trouble managing voices. She came in with a primary mood disorder with psychotic features, and she was able to embrace and manage the symptoms, which was really cool. Graduated from high school, and now she's working with her father to save up money to go to college. And I wanted to share something. I mentioned that I was doing this webinar to one of my participants right now, and she wanted to share a poem she wrote. So I'm going to read this to you. It's called Wait Until the End. It says, I'm losing myself. I'm slipping away. I'm mad at myself. It never goes away. I beat myself up. I let myself down. I'm here to mess up and always look down. I'm destroying my soul. I will never have peace. There is darkness in my soul. It could never have peace. This is talking about her symptoms. And with treatment, continues. I'm finding myself. I will never get away. I look at myself. The smile never goes away. I keep my head up. I never look down. I'm here to beat life up and never let myself down. I'm fixing my soul. I want to find peace. There's still light in my soul. It will reconnect with peace. She's trying to connect with and grieve her illness right now. She's trying to find meaning in what happened to her, and what she really wants is to be able to recover and help other people who are going through the same thing. And this is what we're currently working on. She really wanted me to share that. So there it is. Mm-hmm. And just to kind of summarize everything, early intervention is one of the most important things. It's a team effort. This includes professionals, family members, and of course the individual. Family support is very, very important. The more people, the more families know about what's happening and how to support the individual, the better the person will do in recovery. And also, recovery is possible. So we'll look at the next page. If you want to refer anybody, if you need somebody who needs some help, this is how to refer to our clinic. So thank you so much for your time and participating in this webinar.
Two comments and questions. One,
sure.
I want you to tell the person that wrote the poem how powerful. I mean, it was really a powerful poem that really expressed both her grief and now she seems like she's going into hope.
Hope.
Yeah. And the second thing is we've had some questions about first episode centers. Now I know in the Phoenix area we have your first episode center and we have Valleywise first episode center. Two questions. I mean, with as powerful as these programs, how many should we have for a population of in Arizona of 7 million, or in other populations? What is the best? How many do you need? One for how many per million people would be reasonable? And are these everywhere throughout the U.S.?
I think we definitely need a lot more right now, based on the caseloads and what we to provide, the adequate care that people need. We have a caseload of 60 overall in the agency, so it's 20. We have 3 clinicians right now, so it's 20 per clinician, just so that we can offer the best care possible. So yeah, I would say we need a lot more, just so that people have the care they need, because what happens once we're capped? I mean, people keep transitioning, they keep moving forward, but yeah, we need more.
Yeah, it's a very good question. So if you look at the prevalence, like I said, worldwide of schizophrenia, just that particular disorder, it's 1% roughly, and pretty stable across countries, cultures. So in a population of 1 million, that's just 10,000 folks there that have that. So then if you sort of back into all the other types of disorders, schizoaffective disorder, those who have a mood disorder, take what percentage of that is the young population who would meet FEP, you can start to get kind of an idea about how many services you're going to need. So it's a very good question. And typically in a city about the size of Phoenix, you would have multiple FEP teams scattered throughout. I don't know, Gabby, how much is each clinician as far as your caseload, as far as the folks you guys are doing individual and group work with?
So as I was saying earlier, it's 20 people per person right now. So it's a total of 60 for our clinic. Yeah.
So you can see there. And as far as for medical prescribers, often with higher intensity teams, it's often limited to about 100, maximum maybe 200 people that a prescriber such as myself would be working with that person, because we need to be able to see them more frequently, at least once a month, if not more frequently. So basically, yes, there's always a need for more services. And this is why Valleywise is doing such an amazing job providing a critical service to the community. And we're doing our part as well to try to help support that and do our bit to serve the people who live in our area.
So we have 2 more questions. One is, are there residential settings for part of this treatment? That's one. And 2, what suggestions do you have someone that's over the age of 30 that's now first going through the same first episode? If it's capped at 30, are they out of luck? Or what if they're emotionally 14? No. I mean, so what do you suggest?
Yeah, so we're still actually able to see people. Again, they might not be part of the FEP program, but we don't turn people away. We try to give them care and offer, the same options if possible as well. So people can still come in. They might not be part of the program, as I said, but we won't turn people away.
And what about the residential piece? Do you ever have
It's-
people in a really intense residential setting during the
So
initial?
our program is outpatient services. We don't do residential right now. It's just, but we do have people sometimes who go into residential programs. And so they have their stay there. For example, I have one right now that came into the FEP program, went into the residential care program, and will return once that's complete.
Okay. Well, with that being said, we really, you're getting rave reviews. I think it's something that everyone should know about. I mean, I'm always surprised when even some psychiatrists don't know about it, which is surprising, especially if they're younger. So I hope everyone learns about first episode treatment for the young and trying to interrupt that trajectory towards continual psychosis. So we really need to get the word out. Thank you. Well done.
Thank you so much. And yes, please spread the word. We're, definitely, we can answer questions for people if they want to talk about anything. We can definitely do that.
Yes, and thank you everyone for taking the time this evening to listen to our presentation and to participate. And it is so important that we all really work together to get the word out, about how to do respectful, dignified services for those who are suffering, for their families, because there's so much positive that can be made out of this, that's really motivating and inspiring. So thank you.
Okay, and for those that want
Thank you.
certification or certificates, we go back to the beginning, just email right here, contact@acmionline.com, and we'll send you a certificate of attendance. We're working on getting CEUs, continuing education, but that's still in the process. And up on our website, we also have our upcoming. We're working on some things that I think could be interesting. Coming down the pipe, we're looking at maybe some of the treatment with micro psychedelic drugs that I know they're doing a Johns Hopkins study to talk about these microdoses and what's going on there. Also, we're trying to do one on marijuana. And again, I've been to conferences that say, no one cares if grandma smokes a joint when she has a broken hip, but it's that adolescent mind that you're trying to prevent from going into getting high every day. So that should be interesting too, not pro, not against, but just what is the science with marijuana in the brain and the current doses that it and varieties it comes in. And we're looking at several other ones, but again, if you have topics that you'd like to learn about or other interesting things, send us an email and we'll try to get a person to present on it. Thanks again. And remember, I'll send you out a link to the webinar and a link to the slides, and we welcome all your feedback and your comments. Thank you, guys.
Thank you.
Good night, everyone.
Okay. Take care and be safe.
Thanks, everybody. Bye-bye.
Bye.